while people do still come on, I might do the formal part of the program, which is to introduce our two CML experts. So we have Professor Beppe Saglio. Professor Giuseppe Saglio is Professor of Hematology and Internal Medicine at the University of Turin. Until retirement, he was head of the Division of Hematology at the Mauriziano Hospital at the University of Turin, and previously director of the Department of Internal Medicine at the San Luigi University Hospital of Turin. Professor Saglio is leading expert in the fields of molecular characterization of CML, molecular diagnostics, and the clinical development of molecularly targeted therapies for CML. He's been involved in numerous clinical trials evaluating first and second line TKI treatments for CML. And his expertise has found its way into various treatment recommendations, expert opinions, and position papers that have significantly advanced the management of CML. And also Professor Jane Apperley. So Professor Apperley is chair of the Centre of Haematology at Imperial College London and clinical director of the clinical haematology at the Imperial College Healthcare National Health Service Trust. Jane Apperley's group at the Hammersmith Hospital cares for one of the largest cohorts of patients with CML and has been involved in many CML clinical trials. She has extensive experience in the use of first and second generation TKIs, particularly in the areas of molecular monitoring and mechanisms of drug resistance. Professor Apperley also has a long-standing interest in the ways in which hematological diseases and their treatment impact fertility, pregnancy, and fetal outcome. So welcome to you both. Thank you both for giving up your time and sharing your experience and expertise with us. Without further ado, let's begin with the questions. So we've sort of split this into groups of questions, and I thought we'd begin sort of with CML classification. So right at the beginning, we had a couple of questions come in about the recent WHO classification changes. So perhaps Beppe, can I start with you and ask the question, which classification for CML phase do you use currently? The WHO 2022, which removed the accelerated phase, or alternatively, the International Consensus 2022, which maintains the accelerated phase definition.
I would like also to hear the opinion of Jane, who has directly contributed to these definitions. Personally, I think that indeed I would prefer the WHO definition, because we know that indeed we do not treat different at the moment accelerated phase with respect to high risk chronic phase CML patients. So I think that what is extremely important, particularly with the developments of new TKIs like probably iCMLf, but also ponatinib at the moment, in the future maybe also the Chinese drug tolverembatinib and so on, we will treat with potent TK inhibitors this group of patients. But really I think the accelerated phase diagnosis is really I would say a high-risk form of chronic myelogenous leukemia. So I do not treat differently these patients in a different way. The real difference is between plastic phase and the chronic phase. Which is your opinion, Jane?
So thank you very much for agreeing with the new classification. Just before I answer the question, I just want to correct one of the things that Nicola said in the very nice introduction about me, and it's my fault for not correcting it. I have in the last few months managed to divest myself of my managerial and administrative responsibilities. So I am no longer the clinical director or the chair of the department. I'm just another jobbing consultant like everybody else, and it's quite relaxing and gives me more time to spend with patients, of course. So the issue of the classification, this is not new. This is the first year that I've been involved in the WHO, but I think it's been a topic of conversation probably since the 2009 ELN guidance, where how we treat accelerated phase was already under considerable discussion then. And the background to this is that, as we all know, the older definitions of accelerated phase included things like patients losing their response to prior therapy, which in those days would have been hydroxycarbamide or interferon, maybe even busulfan, the emergence of chromosomal abnormalities, enlarging spleens. Now, these are all things that we now deal with in a completely different way. You are allowed to lose your response to imatinib or even to a second generation TKI, but still be considered in chronic phase and just change to a more potent or a mutation sensitive drug. We also know that if you end up then with simply trying to define accelerated phase on a blast percentage, which is, as a jobbing hematologist looking down a microscope, you can probably manipulate depending on which part of the bone marrow you look at. There's also quite good evidence that patients with blast counts under 20% behave much more like chronic phase, and patients with blast counts more than 20% behave like blast crisis, even if your current definition of blast crisis is a blast count over 30%. Patients with accelerated phase have heterogeneous responses to treatment, with some doing just as well as chronic phase patients and others doing poorly and needing referral to transplant. So it seemed that the previous definitions of the triphasic disease were literally out of date, and we should make some attempt to address this. There are things that are not as included at diagnosis in SoCal or ELTS scores, such as the presence of additional chromosomal abnormalities, but can now be used in the WHO classification to help identify high-risk patients. And there is a practical implication of this, of course, because if you identify somebody at high risk from diagnosis, you will be more aggressive in your use of second-generation drugs if they are available to you as first-line therapy. So I think it's more practical. You have to remember that I have a background in transplant and therefore in the gathering of data in enormous registries. And I know that redefining the phases is going to cause a lot of problems when we try and look retrospectively at patients' groups. But this is something we're just going to have to deal with. One of the other issues that Andreas Hockhaus was always very careful to point out was that by putting patients into accelerated phase categories at diagnosis, we normally rendered them ineligible for any trial of upfront first-line treatment, because that was usually restricted to chronic phase. So I think it has, although it's going to cause some difficulties, I think it has more practical benefits than disadvantages.
Fair enough. Just perhaps as a quick follow-up, a follow-up question was, do you see differences in how you would now treat high chronic phase CML in the future because of this?
High risk chronic phase, yes, I think I've kind of dealt with that, and I think Beppe would agree with me that we would push for those to have a more potent drug at diagnosis if those are available to you.
Absolutely.
Okay. Thank you both. And moving on to something that does come up quite often, again, outside actual treatment of CML. And we had a question come in from the Middle East talking about the fact that the higher percentage of young age group is diagnosed with CML in the Middle East and perhaps Asia and Pakistan, rather than what is considered the West, Europe, the US. This is a question that has come up many times. Beppe, could you give us our current understanding and ways to look at this?
So I would say, rather than the current understanding, is a current question mark, because it's something that we have to solve using really, I would say, good epidemiological studies to understand this problem. Of course, we know that the median age of the patients with CML in the Western countries is higher with respect to the median age that we have in Asia, because there is a higher proportion of young population. And so what is important is just to solve this question, which can have important implication, of course, because there can be also environmental problems related to the higher incidence if this will be confirmed. But the problem is that we need to relate the the incidence of the disease to the age of the patients. So we need really, I would say, great effort to finally define this aspect. At the moment, we know that CML is generally is a prevalence in the older elderly population. So I think that indeed the fact that we have many young CML patients, however, may also reflect on the other side the fact that the percentage, or as you see, there is a way from the graphic point of view to express the different decays of the proportion of the different decays in the population is different in Western countries with the Asian. This is an unsolved question at the moment.
Fair enough. Okay. Thank you.
If I can just add one comment to that, I completely agree that we would have to look at what you might call a relative age of onset, relating to the life expectancy in individual countries. But interestingly, we had started a population based registry a few years ago, and we've just done the first full analysis. And white Caucasian individuals occupy about 85% of the population of the UK, but 15% are of other ethnicities. The median age of onset of CML of people residing in the UK, white Caucasian, is around about 60, and the median age of onset in the Black community and in the Asian community, which in the UK basically means the Indian subcontinent, is between 40 and 50. So that's actually quite interesting, because most people aged between 40 and 50 will be people who were born in the UK. So it's a very interesting question and unsolved, as Pepe says.
Absolutely, and perhaps I will jump a bit from where we were going to go. So one of the questions that did come in, which sort of perhaps leads on from that, but that may be a question. So in your opinion, is CML genetically transferable?
No, I don't think it's genetically transferable.
No. There are very, I would say, have been described very few anecdotal cases in which there was a CML within the same family. I think that are less than 10 so far, so I do not think that is genetically transferable.
Thank you. Okay, so moving on to TKIs. So looking perhaps specifically at perceived risk of second generation TKIs. And so would you consider, so I'll ask this, Jane, I'll ask this to you. Would you consider switching a patient in MR4 on a second generation TKI back to imatinib to prevent long-term side effects from the second generation TKI?
I think that very much depends on the individual circumstances of that patient. If that patient was tolerating the second generation drug very well and had no immediate reason to switch them because of adverse events, I would simply leave them on the second generation drug. If they were tolerating the second generation drug poorly, and you were quite convinced that had you continued with imatinib, you would have achieved the same response, then that might be an indication to switch back. But normally you can find an alternative second generation drug. So I think what I'm saying is it depends very much on the reason you switched to a second generation drug in the first place. Maybe you started with a second generation drug, and whether the patient was tolerating that drug well at the moment.
Yes, absolutely agree. I think that I wouldn't change it to imatinib, of course, but eventually I can try to decrease the dosage of the second generation TKI.
Thank you both. We've also had a question coming from Argentina. What is your approach after a CML patient relapsed with a second generation TKI as first line? Would you then switch to another second generation TKI, move to ponatinib, to transplant, or would you look to include the patient in a clinical trial if one was available? Beppe, perhaps you would like to answer this first?
Yes, I think that indeed, in my personal opinion, what I'm doing is just to switch to ponatinib at the moment. In Italy, is also available, not yet registered, but it's possible to ask for asciminib. So probably when we will have a case directly resistant generation TKI, we can decide to on one side to look for mutations. If there are mutations like the 359 mutation, I would prefer to still use ponatinib. Otherwise, probably I will move to asciminib. I will try to include asciminib in a clinical trial also as compassionate use. I think that transplant as a second line of therapy can be just related to exceptional cases. I think that Jane can have a better opinion on this, a better look at experience on this as a second line of therapy of CML. What do you think, Jane?
So what I would say about this question is the devil is always in the detail. The question said that the patient had relapsed. Now, I do not know what that means, actually. But a patient who has had a very good response to a second generation drug and then loses that response is a big worry. So after you have checked for compliance, which is potentially an issue over time, I would definitely tissue type the patient and any potential relatives, because if they were to fail, whatever drug you choose next, you may have to move to transplant quite quickly. So you would probably want to know if a donor was available. You would obviously do a mutation analysis, which might direct you towards an appropriate TKI, because again, responding very well and losing a response is really quite a worry and is more frequently associated with the presence of a kinase domain mutation. In general, if there's no kinase domain mutation, I would switch, and no major contraindication, I agree with Beppe that I would switch to ponatinib. And if ponatinib is poorly tolerated, then at least you will have satisfied the current criteria for asciminib, which is the failure of 2 or more TKI. Although whether asciminib would work after failure of ponatinib is another big issue, and then the issue of transplant becomes more relevant.
Thank you both. So perhaps looking in more detail at managing toxicities, question came in regarding dasatinib long-term use, and whether or not there is any correlation to hip joint issues or degeneration.
No, I think that is something which is probably, I do say, I do not have experience of this type of relationship between dasatinib long-term use or the hip joint degeneration and so on. So I think that these are probably associated with the age or the specific, I would say, condition of a individual patient, but I don't think that is related to the dasatinib use.
I would largely agree, although, of course, if it's a matter of duration of exposure, we may see other long-term side effects, and this might be one of them. I mean, if you're looking after an older population of patients, you will inevitably look after patients who require hip or knee replacements at some stage because of degenerative disease. We have identified a couple of cases of avascular necrosis in patients who have complained about their hip pain in our clinics, but whether they're associated with the drug is a completely different question. And in fact, both those patients were on nilotinib, so maybe irrelevant to this particular query.
Another question's come in sort of regarding patients needing dialysis. So are there specific precautions for CML patients on TKI needing dialysis? And a little caveat, the question is specific about heparin and any interactions or precautions.
So in a way, the fact that patients on dialysis it sounds terrible, but in some ways it's a relief, because you don't have to worry about the patient who already has coexisting comorbid renal impairment that you don't want to worsen with drugs. And of course, almost all the drugs, but particularly imatinib and bosutinib, are seemingly associated with deteriorations in long-term renal function. So actually, the patient being on dialysis should open up the possibilities. Beppe may want to comment about the pharmacokinetics of the drugs and whether it's better to be using a short-acting or a long-acting drug, but we don't take any precautions specifically in the context of heparin.
No, so do we? But I think that it's important, of course, during the diagnosis, just to see that the dasatinib, I would say half-life is very, very short, for example. Therefore, I would say that if you perform dialysis, you must be sure that the patient has a sufficient time for the exposure to the drug. So I think that this is what you have to take care, but it's quite easy to arrange, I would say, and to try to have, I would say, this information look also the response of the patients, because the response of the patients is.
One issue that may be underlying this question, I guess, it is thrombocytopenia, which is not infrequent on any of the drugs. And then I think that's an issue of discussion between you and the renal physicians, but you aren't going to be able to dialyze without some form of anticoagulation, so this will just have to be managed.
Well, so we've had a couple of cases come in looking at toxicities, and I'm going to share my screen so that we can see these. So this is a case from Brazil, hematologic toxicity. A lot of detail in the case. So this case is a CML patient in accelerated phase of diagnosis with recurrent episodes of neutropenia in second-line treatment with dasatinib. He has had 3 haploidentical donors available. What would be your approach? Transplant with one of the donors, or third-line TKI, ponatinib or asciminib if available? If your choice is the TKI, which one would you choose first?
Okay, so briefly, if people haven't got time to read this is a guy of 30 who was diagnosed with CML in accelerated phase, 12% blasts. So in the new definition, he would probably still be chronic phase. About 9 months ago, started on imatinib, developed grade 4 neutropenia, and switched to dasatinib. And his bone marrow and PCR results are detailed in May, June, and September 22. So he is not responding particularly well to either drug. I guess he was switched to dasatinib in March, so in June, which would have been 3 months on dasatinib, his PCR is only just under 10%, but of course that is 7 months since his diagnosis. He's on a very small dose of dasatinib, 20 milligrams a day, and that's probably inappropriate for somebody who was high risk at the time of diagnosis. Hematological toxicity is common with all the drugs, and it's a real worry if it happens with imatinib, because it's very hard to find another drug that won't do this. In my experience, dasatinib is particularly difficult, particularly with respect to thrombocytopenia, actually. So what ends up happening is that you either have drug holidays or you drug reduce, which is not necessarily in the patient's best interest. So I don't know because it's not mentioned, but I'm assuming that you're trying to support the white cell count with G-CSF. And if you're not, that might be one thing you might do. Yeah, because the answer came yes. I think if it's available to you, I would try asciminib rather than ponatinib. Unless, of course, the latest PCR is, I see the last PCR is still 12%. So 9 months after diagnosis, not doing well. My personal feeling about this guy is that he's coming to transplant. And while you're preparing him for transplant, you might want to try some asciminib. But I think you'll run into the same problems with hematological toxicity. he's young, and this doesn't look to me like it's going to work.
Fair enough. Let's have a look at the second case then, which is more looking at going back to hepatic toxicity. Jane, perhaps you could take this one as well. I'll ask the question and then perhaps review the case. So the question for this case is, would you switch back to imatinib? It was interrupted because of a lack of medication, but now supply is okay. Or would you stay with nilotinib 400 milligrams, considering this patient is high-risk SoCal? Would you consider switching to another TKI?
Well, this is difficult actually, because the patient was, you say, it was high-risk SoCal. Is that right? Am I missing it? High-risk SoCal, and has been diagnosed about 9 or 10 months. So no imatinib available, but got nilotinib. That's an interesting dilemma that I haven't come across before. Treatment interrupted for hepatic toxicity. I guess I would ask why you started 400 BD for a patient in whom you had no real reason to think that they would be resistant, and whether you could immediately think of knocking back to 300 BD, which is the recommended dose for a newly diagnosed patient, and 400 BD is reserved for patients who are resistant, which this patient is not. If you're comfortable about that RQ-PCR of 0.006%, so already in an MR4 at probably not much more than 4 months after starting treatment, which is a quite remarkable response actually, I think you could do either. You could either switch back to imatinib, or you could dose reduce on the nilotinib, and potentially even in 6 months or so's time, dose reduce further on the nilotinib if you've maintained this really excellent molecular response so early in treatment. Of course, the concern in the last entry for the 14th of September is that the patient has developed some mild liver function abnormality. So you've got to, unfortunately for me, your bilirubin, units of measurement of bilirubin are different from mine. So I can't do it fast enough and translate. But if this is a hyperbilirubinemia, nilotinib is the drug that is most associated with this in Gilbert syndrome. So I would look for the UGT1A mutation and see if that's present.
Absolutely.
And then I wouldn't worry about the hyperbilirubinemia. More concerning is the mild transaminitis, which might be another reason to return back to imatinib. And I think Beppe was trying to come in.
Yes, I'm trying to come in just to say that in my personal opinion is that indeed the evaluation if this is a direct or indirect bilirubin will be probably enough. It is mainly indirect, is probably Gilbert syndrome, and therefore I would not fear. I would continue with the nilotinib 400 milligram. I have a similar case which is responding very well. 400 milligram probably is enough. It's also associated with a lower risk of cardiovascular events and so on. So I think that there is no reason to go back to imatinib or so on for this only high, or modestly high increased bilirubin. So I think that I would continue that.
Can I challenge you that a little bit, Beppe? Because the patient has got a fantastic response.
Yeah.
And they're 24 years old. So maybe you're really lucky and this woman is teetotal and is incredibly fit in every other aspect. But to have restrictions put on you because of a transaminitis at the age of 24, which potentially could be with you for the rest of your life, I think that does require some consideration as to whether you can get the liver function back to normal. No?
Yes, but I would still evaluate the situation for a certain period of time, and maybe probably, but also iCMLf, which is the only one with such an incredible response to go back to imatinib. I would say, because being 24 years old, probably is better to stay on a more potent drug for a while than to try discontinuation. So we do not need to continue for the entire life of this lady, this female I would say, woman who is, of course, she needs also to stop any kind of TKI therapy if she wants to become pregnant in the future and so on. So I wouldn't go back to a, I would say, even if there is apparently at the moment a little bit of toxicity, I would consider also the expectation for TFR and so on.
Okay, so a compromise between us might be to continue a reduced dose of nilotinib for at least 2 to 3 more years, attempt a trial of treatment-free remission. If it's successful,
Yes.
Fantastic. If it's unsuccessful, you might want to start it back on imatinib.
Yes, this is a possibility. The possibility is maybe, you know, iCMLf is also increasing a little bit the transaminitis, but certainly in 2-3 years, maybe we will have other drugs which are less toxic for the liver and even more potent than imatinib. So I think that we must carefully follow the situation. But for the moment, I think, in particular, as you said, if there is the Gilbert syndrome, in this case, you can also verify it, I would say, by saying, please make a, not, I would say, not to take a blood sample immediately after a long fasting period, but maybe just to eat something and then to look for bilirubin. This will give you already, I would say, sort of response if you cannot perform the mutation analysis for the Gilbert syndrome.
Already. All right. Thank you both. Different but good advice. Perhaps now, so we'll go back to the questions that we were considering. Perhaps we'll move on to CML and pregnancy. So Beppe, perhaps I can ask this one to you to begin with. How often do you consider it optimal to monitor with PCR a pregnant woman who has stopped TKI treatment? And when do you decide beginning interferon or hydroxyurea?
I think that, of course, we have to monitor her, not every month, but every 4-6 weeks, just to see if there is a continuous increase and so on. Then it depends also on the level of the BCR ABL that you have immediately after stopping the TKI, because it can be a little bit longer or not. Then generally, unless there is a loss of complete cytogenetic remission, we are not starting interferon or so on, so other types of procedures. So we wait at least for a value of BCR ABL which is above 1%. If it is lower, we expect and we monitor the patients every month, every 6 weeks maximum. What do you think, Jane?
Completely agree. I'm not a big interferon fan, so I do try and avoid it. I mean, again, all these discussions are more nuanced because it depends on the level of PCR at the time of stopping, the kinetics of the PCR after you stopped, and the gestational position of the patient, whether they are in the vulnerable period in the first trimester or whether the baby is safer as the pregnancy progresses. But I don't think there's really any need to use hydroxycarbamide unless you're in the very unfortunate situation of the patient having an extremely high white count that you don't feel that you're going to be able to get down with interferon. And then, I mean, what isn't in this question is whether this patient presented in their pregnancy, whether they became pregnant when they were having a good response to a TKI. But I would only use hydroxycarbamide if the count was way up. But in that situation, you could also make an argument for using a TKI because the risk to the mother probably outweighs the risk to the child.
Thank you. The next question, again, looking at pregnancy or fertility, is sort of looking, so what are the preparations needed for somebody looking to become pregnant who is 30 plus and wants to have children while on TKIs? How do you minimize the risk? And then a second part to that question is, how about an older female, so 40 years plus, who would like to become pregnant? Is the preparation the same? and is the risk the same? So Jane, can I start with you?
Yeah, sure. I mean, I think that we are now getting some very familial patterns to the situation of patients who want to become pregnant. So the really lucky patient who has been on treatment for a little while and is in a position where otherwise they would have been offered an opportunity to stop for a trial of TFR, so MR4 for at least a year, should be treated exactly as a TFR patient. They come off the drug, you monitor the PCR as you would for a TFR attempt, perhaps once every 6 weeks. If it's rising, then you have a conversation with the patient about whether it's rising and they're not pregnant, you have a conversation with the patient about whether they want to go back perhaps on a more potent drug and reestablish their remission and try again in a couple of years' time. If it's not rising and they're not pregnant, then you just leave them off the drug exactly as you would a TFR. If it is rising and they're pregnant, you may have a little bit of a problem, but that goes back to the answer to the previous question, that I personally wouldn't introduce anything until they'd lost at least complete cytogenetic remission. For the patient who's not in such a good position, so they're not in a position for a trial of TFR, then you have to have a very frank discussion with that individual about the risks that they are taking. And in that case, depending on how they're responding, how long they've been diagnosed, etc., it doesn't really matter how old they are, but obviously more relevant for older patients, whether you have any possibility in your local practice of in vitro fertilization strategies such as embryo creation and implantation, or embryo creation and freezing until the patient is in a better response. But that's obviously much easier to do in wealthy countries than it is in poorer countries. Most patients in chronic phase, you can get through 9 months without much risk of them progressing, but they have to understand that there is a risk of them progressing if they stop treatment to have a child. I mean, I don't know what percentage Beppe would put on it, but it's got to be less than 5%, but it's there.
Yes, I agree. I agree with you. I think that, of course, you need to say it's very difficult to establish general rules because patients are different, they have different expectations and so on. So I think that it's very important just to consider the situation, and knowing that indeed the TKI therapy can be, of course, teratogenic and can cause some problems. So I think that it's important just to stop the therapy in any case, but at the moment in which we have decided to stop, whereas for a 30 years old lady, we can expect a little bit longer. Of course, for 40 years, the difference is that maybe they are, I would say, trying really to have babies, because we are approaching, I would say, the end of the fertile period. So I think that it's very well we need, as Nicola Baccarani said, to be doctor and to understand and to evaluate situation for situation without having rigid rules.
Thank you. Moving on to a different topic, a question came from Uruguay, looking at specifically after the pandemic, several patients who unfortunately have evolved into blast crisis. So there are two separate parts to this question, and perhaps Jane, if you would answer first. We would like to know what treatment you suggest for patients with myeloblastic blast crisis in candidates and non-candidates for consolidation with allotransplantation. So we might leave it there. So let's look at just that question first.
Okay, I can, if it shortens the answer, I can say that I probably have the same approach to both myeloblastic and lymphoblastic transformation. So in the patient who is a candidate for transplant, I would use a combination of high-dose chemotherapy. We tend to use in the UK Flagida. It's good for both myeloblastic and lymphoblastic. In combination with the TKI, there's a big debate as to which TKI you can use, because some of the TKIs are not licensed for blast crisis and some are not available in some countries. There's also a question of whether you should be thinking about CNS disease and whether you want to try and use either a drug with some CNS penetration, such as dasatinib, or whether you use intrathecal, additional intrathecal injections of chemotherapy. Now, in the UK, we had a small but very effective study of the combination of ponatinib plus FLAG-IDA, and anecdotally, these are pretty much the only patients who are returning to see me in clinic after a transplant in a second chronic phase, which was induced by that combination. The number of survivors that we have of transplant in second chronic phase following blast crisis on a TKI is vanishingly small. So the answer to the question about the patient who is not eligible for an allogeneic transplant is a frank conversation that this condition is fatal, and how the patient wants to pass the last few months of their life. If they have high dose therapy plus a TKI, they may get a nice second chronic phase, and it potentially might last a little bit longer than the effect of a TKI alone, but that has to be balanced against several weeks inpatient hospital stay versus being home with your family. Beppe?
Yes. No, yes, I fully agree. I think that what you said is totally in agreement with what we are doing at present in Italy. I would say that for lymphoblastic blast crisis, which is the second part, I do not know if we have to evaluate this also in the moment, or we have to discuss it later on.
I think Jane's point was that her answer was the same, so it wouldn't make a difference. But if you have a difference, then that would be welcome.
I think that certainly in this case, I think that for the lymphoid blast crisis, we can avoid, at least in Italy's therapy at the moment, with ponatinib is the best one, as association with the ponatinib together with people with BICE antibodies. It's highly effective even in patients who are not undergoing for transplant. Although patients who are, I would say, can be, of course, can be moved to transplant. I think that I would prefer to move it to transplant, of course, even because at the moment the therapy, we do not have a longer follow-up of a different trial without transplant.
Fair enough. I have one more question on transplant before we move on to a case that's coming into the chat. But Beppe, perhaps you would give your opinion on a blast phase patient with comorbidities for cardiovascular disease. What options would you consider? TKI, and which one? Chemotherapy only, or chemo plus TKI?
It depends if the blast crisis is myeloid or lymphoid. I would say that this is extremely important. I would say that in any case, more potent TKI for patients with, depends also the degree of cardiovascular problems that these patients have, because if it's simply comorbidity, I would say it depends of the degree. If it's a very high contraindication to use a specific TKI like ponatinib and so on, maybe chemo and then a different type of TKI, not so, I would say, involved in cardiovascular toxicity like dasatinib can be used. If this, if we have a low degree cardiovascular risk, probably, but there is, I would prefer, of course, to use a more potent TKI, like ponatinib, and eventually associated with chemo, if this is feasible and useful for the patients. In particular, I think I tend to not use chemo for elderly patients with the lymphoid blast crisis, which in our hands are the most frequent at the moment after TKI therapy. Jane?
I completely agree with the proviso that I still think lymphoblastic crisis is a fatal disease. So
Jane?
we don't really have a distinction between the two.
Fair enough. So perhaps we can now look at the question that's come in the chat. So this is a 40-year-old male patient treated with an nilotinib in first line and with MR4 for more than 2 years. Developed dyslipidemia, managed with a statin, but now has carotid stenosis, less than 50%. Discontinuation is proposed, but the patient doesn't want to stop therapy at this moment. Would you prefer to switch to imatinib or another second generation TKI? And I guess if a second generation TKI, which one?
I would try to lower the dosage of nilotinib. How much nilotinib is taken? 300, 400 milligram twice a day? Or I would try to decrease.
Oh, 400 a day.
400 a day.
Oh, right. I'm treated for more than 10 years now. That's come in, treated for more than 10 years.
No, I would try to stop at this point, because if it's 400 milligram a day, you can try to stop and eventually having to restart the therapy if you have at your disposition the possibility to use some other second generation, because this is a form of side effects and so on, but the drug is still effective. We can move to dasatinib or to bosutinib, I would say, rather than to go back to imatinib.
Except that going back to imatinib and maintaining the same level of response might give the patient the courage to stop, because it's like a dose reduction.
Yes, this is correct that you are facing.
Okay. Jane, did you have anything from your perspective that you would do differently?
No. I probably, with a 50% carotid stenosis, the problem with that, and the patient is young, the problem with that is that if there is an adverse event, it's going to have devastating consequences. So first of all, I talked to my vascular surgeons about whether they think they can do anything, but I probably would get them off nilotinib. And as Beppe said, MR4 for 10 years, I really work. You maybe could present it as a bit of an experiment, that you give them a holiday off for 3 or 6 months, see what happens to the PCR, and also see what happens to the carotid. So yes, you would be presenting to the patient, not the ultimatum of stopping forever, but something that may improve both conditions.
Okay. We have another question that's come in, sort of looking at TFR or not TFR from the Philippines. So this question is, would TFR be recommended for a 27-year-old on imatinib in deep remission for 10 years? What are the risks of not attempting TFR, i.e. long-term effects of imatinib in this age?
No, yes, I think that I would say the quality of life without imatinib is certainly better with respect to the quality of life with imatinib. So being this guy 27 years old, I think that it's important for him to have a normal life. So in deep remission for 10 years is the best, I would say, condition to try to stop TFR. Maybe you can start by decreasing the dosage of imatinib from 400 to 300, as it has been shown in the Destiny study. And then if there is not an increase of the BCR-ABL, you can stop it definitely. But I would say for several reasons, to be defined after 5 years as a CML cure is extremely important for this guy. And so long-term effects of imatinib, we have now a follow-up of 20 years. We know several things, but what is important, in my opinion, is the quality of life and the concept to be cured. And because these are very important also social implication for the life of such a young patient.
Yeah, 100% agree.
Absolutely. Perhaps I will ask one more question. Just looking at generics, Beppe, So this is a question that's come in from a country, a lower middle income country. So we have started to treat patients with generics because of the public health policy. We have generics for both imatinib and dasatinib. Besides monitoring these patients closely, what would you suggest?
To use generics, of course, because you have finally at disposition two drugs which are very, very good. I would suggest that as first-line therapy, you can use imatinib, but also you may also think to start with a lower dose of dasatinib, particularly if the patient we have data now that 50 milligrams of dasatinib per day are probably sufficient, and in low-risk patients certainly. So it depends on which patient, which is the risk of the patients, of course. And on the other side, you can also decide to start with imatinib, and then to maintain dasatinib as a second option in case of not an exceptional response. But this is the situation that we will have very frequently in the future, to have at our disposition not only two, but maybe 3 or 4 different TKIs. So I would say we have to change a little bit our attitude to use the TKI in a more, let's say, elastic way. So without being so rigid, we can decide in any case, because this is not particularly affecting also I would say, the public health finances and so on. So I think that it's very, very important to this situation. But I wouldn't behave substantially with respect to what are the current guidelines.
Thank you. Jane, did you have anything to add?
No, I completely agree with Beppe. The only thing that I could add is that we in the UK have access to a relatively limited number of generics, which have had to pass some kind of regulatory approval. I remember Karolina Pawlowski saying to me several years ago now that they already had 17 different brands available in Argentina. And what I don't have experience of is whether all generics are equal. So if you have a concern about that in your country, you may want to use try to use one of the more established ones that are widely used.
Absolutely. I totally agree with you.
Yeah.
But
absolutely. There is sort of, for people who are particularly interested in generics and using generics, there is a presentation by Geoff Lipton in the iCMLf Knowledge Centre, which specifically focuses on the use of generics. So that might be worth having a look at for those who are interested. So I think at this point, I am going to wrap up the discussion. It's been a really great discussion. I appreciate both of you for sharing your expertise in situations where you don't have the full details of the cases that we're trying to discuss. So it is sometimes difficult. So I appreciate you taking the time to do this. And for all of those of you in the audience who submitted questions, again, we received so many more than we've been able to cover. We will be distributing sort of those questions and answers. And if you are also interested in submitting cases for the iCML experts to discuss, we have the clinical case discussion forum on the iCMLf website, which is always worth submitting your case there, and lots of discussion occurs online. So with that, I will say goodbye and thank you again.